we want to be able to identify new targets for therapeutic intervention. So there are a few things that make genetics possible in this era that's beyond technology. So one is our really tremendous population. So the population of greater than 7 billion, there's more than 14 billion human alleles on the planet, one from mom, one from dad. Most mutations that are compatible with life are likely present somewhere in the population. Rare recessives appear due to intermarriage within families. And what I've found most recently, which has been really tremendous, is that social media has really driven us to be able to find even the rarest disease in the most remote location, because I'm getting messages on every platform there is about unsolved, interesting cases that, what I always like to say, haven't read the textbook. And those are precisely the things that we want to study in the laboratory. And despite the fact that we've made really enormous progress in understanding the human genome, and now know that there's about 30,000 genes, we have limited understanding of function for about 5,000 of these. So I've always thought of the skin as an incredible genetic model system. And so we recognize that there are a few core functions of the skin. It's obviously a physical barrier to injury and infection. It's probably the most important physiologic barrier to water loss that there is. It has roles in thermoregulation and in communication. And in a normal average individual, there's 85 billion cells. And every day we need to generate 3 billion new ones to achieve simple replacement. And so as we age, we see spots that appear in our skin. All of these are the result of genetic events. Some are from sun damage, but some are just from the peril of replicating DNA. We know that there's a basal error rate behind copying DNA. So if we think about the epidermis as consisting of bricks and mortar in a bricks and mortar model, we can think of the bricks as being things like cells and structural proteins, the mortar being lipids and secreted proteins, and the foundation being the dermis and adhesion proteins. We recognize that the epidermis is primarily composed by a single cell type, the keratinocyte, that undergoes a regular pattern of gene expression that allows it to change function from the basal layer to the stratum corneum. So obviously at the basal layer, we need to have integrity, we need to be able to stick. And as we move up to the stratum corneum, we need to undergo the process of elaborating lipid. We need to be able to start cross-linking proteins. We need to undergo programmed cell death so that we can actually ultimately go through the process of proteolytic desquamation at the stratum corneum. So what happens when there's defects in the bricks and mortar? Well, we see clinically obvious phenotypes. And so shown here are 3 cardinal disorders. The first, lamellar ichthyosis due to mutations in transglutaminase 1. TGM1 is something that I like to think of as being a bricklayer. It's important for cross-linking proteins to make a normal stratum corneum. Dystrophic EB, obviously defects in Cal7A1 in this case leads to blistering. This is a defect of the foundation. And finally, we see a somatic mosaic disorder appearing in a localized distribution. This is an epidermal nevus that's due to mutations in HRAS. Here we can think of HRAS being an architect of differentiation. And when we have mutations, the architect's gone wild and is just throwing bricks on top of the pile. So what are the discovery opportunities that remain in genetic skin disease? Well, I think that there are quite a few. So first and foremost, we'll be able to solve simple Mendelian disorders that remain, but we're also going to be able to go after disorders that were previously intractable to genetic analysis. That is, disorders that don't run in large pedigrees and transmit disease from one generation to the next. And so this has really been the bread and butter of our laboratory. So we've been able to examine dominant traits with high lethality or really impaired reproductive fitness that are mostly due to de novo mutations, that is, new mutations arising within the affected individual, not present in either parent, which we can find by sequencing parent-offspring trios. Traits with high locus heterogeneity. These are disorders that are caused by mutations in many different genes. I think ichthyosis is a prime example. Mutations in more than 50 different genes can ultimately converge on the phenotype of redness and scaling that we know as ichthyosis. We'll be able to solve somatic or mosaic traits, which I'll talk about today. And in the course of doing genetic discovery, we also have the opportunity to do a lot of genetic diagnosis, which I think has also been an important part of what we've done. So I'll begin by talking about mosaic disorders. So every time I give this talk, people send me photographs of mosaics that they see. And it turns out mosaics are incredibly common in daily life. And so Cliff Wheel from Purdue sent me a bunch of photos from the plant kingdom. And you can see that there are regional variations in pigmentation on this palm frond. this single leaf of this impatiens, and this apple, which has 50-50 pigmentation. But this golden retriever and this horse illustrate other important principles of mosaicism. So we recognize that mosaicism occurs when a mutation occurs during development or during subsequent growth. The timing of the mutation will determine whether you have relatively localized mosaicism, like this focal coat color mosaic that we see in this golden retriever, or if we have an earlier mutation, which has the opportunity to migrate within the organism and places the individual at much greater risk of having systemic involvement, depending upon the nature and the expression of the affected gene. And so this horse, instead of having a localized patch of coat color mosaicism, has multiple different whorls of mosaicism, and they're distantly located, which really speaks to the idea that these clones can arise early, migrate, and then populate different regions. And I think that this is one of the things that we need to be thinking about as we're counseling our patients about their mosaic lesions, because even if we have a relatively small burden on the surface of the skin, we don't know where that clone migrated internally. And it's hard for us to be able to very precisely indicate risk of having affected offspring. But overall, timing does really determine risk of systemic burden. So how do we do gene discovery in mosaic disorders? First and foremost, we need to be able to determine the affected cell type. That's easy in disorders that follow lines of Blaschko. So Alfred Blaschko in the 1800s looked at a bunch of children with epidermal nevi and said, gosh, they always follow these exact same patterns in the skin. And so he didn't know it, but at the time he was defining the dorsoventral migration patterns of keratinocyte precursors, which are very reproducible within individuals and within organisms. We know that there are many different types of mosaicism that we can see, and it's largely related to the cell type and the nature of the mutation that underlies it. So once we know what the affected cell type is, we can isolate DNA from it. We can do this by doing a biopsy and culturing the cell type of interest. We can use laser capture microscopy to specifically cut affected cells out of formalin fixed blocks. We can core paraffin-embedded tissue as well. All of these give us ways to isolate affected cell DNA. We need unaffected cell DNA. Now, the perfect control is adjacent normal skin, not always as easily accessible. So we can use surrogates. We can use peripheral blood. We can use saliva DNA. And we can use unaffected cell types within the same exact biopsy itself. There's always peril in this because we don't know the degree of mosaicism, but it's a good way to get started. We can employ a variety of different genomic investigative technologies that include exome sequencing, genome sequencing, and transcriptome sequencing, and even start thinking about even epigenetics now using paired DNA from these samples. We then look for single nucleotide variants that are present uniquely within the affected tissue that are predicted to be damaging, and those deleterious variants that are unique to affected tissue are likely to be causal overall. The gift of mosaic disorders are young children that don't have a lot of UV signature mutations, so our burden of mutations is low, but we can use this approach to identify mutations across the lifespan. So as Bill mentioned, we've used this to investigate a variety of different disorders, including Nevus sebaceous with HRAS, NRAS, and KRAS mutations, the exact same mutations that we see in many different malignancies, interestingly, causing one of the most common hamartomatous disorders of children with loss of hair and sebaceous hyperplasia, an increased incidence of primarily benign neoplasms. Linear syringocystadenoma papilliferum caused by BRAF V600E mutations, in this case arising just within the skin without significant malignant potential. Porokeratotic osteal and eccrine dermal duct nevus due to GJB2 mutations. Interestingly, we can see pedon arising in individuals who have KID syndrome, which gave us some idea that this might be related to GJB2. We've looked at a variety of non-involuting congenital hemangiomas, identifying mutations in RAS, GNA11, and GNA14, both in congenital lesions and in acquired classically known pyogenic granulomas. And finally, we've also identified a new syndrome, the cutaneous skeletal hypophosphatemia syndrome, which again shows HK and NRAS mutations in a variety of different types of mosaic skin lesions, including epidermal nevus, nevus sebaceous, and in this case, a giant congenital melanocytic nevus. But these patients have widespread systemic involvement with hamartomas throughout the organism, including splenic hemangiomas, brainstem lipomas, and ultimately, all of these patients have sky-high levels of FGF23 with evidence of multiple bone fractures, thinning and bowing of the long bones, resorption of the distal digital tips. These patients are at risk for a variety of different complications of this. We know that FGF23 is a phosphatonin, which makes these patients pee out phosphate quite significantly. What we ultimately determined is that, in fact, CSHS is a disorder where there's multi-lineage mosaicism, and in fact, we have the same RAS mutations appearing in bone. RAS is an important part of phosphate sensing, and when there's hypophosphatemia, RAS is activated. So when you have a constitutively activated RAS signal, it gives a low phosphate signal throughout, which leads to the elevated FGF23 levels. So I'll tell you about a couple of other disorders. So the first is Nevus comedonicus, which I think is very interesting, and we continue to study the pathophysiology of this disorder, primarily because we're very interested in how rare manifestations of mosaic disease might be able to give us insights into more common disorders like common acne, which has at its heart comedones, which are the lesions that we see in Nevus comedonicus. And John Levinson, a really talented MD PhD student in the lab, who has since gone on to fellowship training, did this work. So he identified initially 3 patients who had linear configurations of comedones. And what's really interesting about these patients is you can rarely see syndromic manifestations with ipsilateral cataracts and skeletal abnormalities. They present at birth with smooth patches. Comedones appear in childhood, and inflammatory cysts typically appear in adolescence, around the time that you'd expect to see inflammatory acne, showing that comedones serve as the nidus for inflammation. Now, shown here are our 3 patients. You can see in NC101, this is a patient that has these giant open comedones. They also have evidence of scars and inflammatory cysts that are present. NC102 is a younger patient, just large open comedones, but NC103 illustrates another important feature. That is, this is a Nevus comedonicus that arises on the scalp. And what you can see is that, in fact, everywhere where we have one of these giant comedones, we do not have a hair. So, of course, comedones are the primary lesion of common acne. So we're very interested in understanding this disorder. And the first thing that we try to do is we try to do good phenotyping. And part of this is histologic examination. And so if we look at the lesion that's present on the scalp, we can see that it arises within otherwise normal hair follicles with normal adnexal structures. But within the comedonal lesions, we can see both comedones and deep cysts. And instead of seeing this glassy keratinocytic lining of the hair follicle that we would typically see, we see a significantly more basophilic and acanthotic lining. And we also see that the lumen is filled with keratinaceous debris. We lose adnexal structures as well. If we look at these lesions on the body, we find that we see an invagination that has an interfollicular epidermis-like lining, again, filled with keratinaceous debris. And so we set out to understand the genetic basis of this disorder. We used paired whole exome sequencing. We found, in fact, in all 3 of these cases, there were somatic NEC9 mutations. Interestingly, in NC101, there were 2 adjacent mutations that happened by chance that led to the same overall consequence. And these fell in a gene called NEC9. Now, NEC9 consists of a kinase domain and an RCC1 domain. We know that when you delete the RCC1 domain, it leads to activation of the kinase. And so the RCC1 domain is a regulatory domain. And so finding these tightly clustered mutations, we suspected that, in fact, these mutations led to gain of function. Easy to understand this, the mutation within a kinase domain to lead to gain of function. But in fact, knowing that the RCC1 domain is an inhibitory domain, we might imagine that these mutations are releasing that inhibition. And so we set out to understand this in a variety of different models. So what do we know about NEC9? We knew it was a serine threonine kinase, which regulates cell cycle and checkpoint control, controls spindle dynamics and chromosome segregation. We knew that downstream effectors like NEX7 are known to regulate NLRP3 inflammasome activity, which is interesting as you think about the inflammatory acne component of this. We also know that NEC9 undergoes progressive autophosphorylation by CDK1 and PLK before it becomes catalytically autophosphorylated at residue T210, which will be relevant to our further studies. We also, around the time that we were doing this work in somatic disease, had other colleagues who identified that loss of function NEC9 mutations cause a lethal skeletal dysplasia within the Irish traveler population, which had prenatal demise, but no detected skin disease. So contrast between loss of function and a presumed gain of function. So the way that we study all of these genes is we overexpress both wild type and mutants in cell lines, in this case in keratinocytes, typically using an HA tag and using native antibody. And what we can see is we can get relatively equimolar expression of wild type in each of our mutants when we use HA or NEC9 antibodies. We have moderately good protein loading when we look at beta-actin. But when we look at phosphorylation of this critical terminal residue, threonine 210, we see we get a little bit of activation when we overexpress wild type, but massive activation when we express both the kinase mutant and the RCC1 mutant, suggesting that, in fact, our original hypothesis was likely to be true. So what's the consequence of this? Well, going back to tissue, we can do some immunostains that are characteristic of the hair follicle. And the first thing that we decided to stain was K15, which typically marks the stem cell population within the bulge of the hair follicle, shown here. And the left panel is all going to be normal hair follicle. What we found is that we had K15 expression both within the comedone and the cyst of our Nevus comedonicus lesions, but it was throughout the entire follicle and cyst instead of being localized to the bulge. We also found loss of typical hair follicle markers. So we lost expression of K6, which is present within the companion layer of normal hair follicles, but is absent in the follicle and cyst of Nevus comedonicus. We also lose AE13, a marker of the medulla, present within normal hair follicles, absent in the follicle and cyst of our Nevus comedonicus lesions. Then we thought, well, looking at that lining of the comedones looks a lot like interfollicular epidermis. So we took a gamble and we stained for keratin 10, which we know is absent from hair follicles, but in fact is expressed throughout the follicle and the cyst of Nevus comedonicus. And so this gave us the sense that, in fact, we had some markers of hair follicle with this expansion of K15, and we were forming a normal invagination, a normal induction of a hair follicle, but we were ultimately undergoing a fate switch as we're seeing expression of K10 within the follicle and within the cyst. And so ultimately we determined that these gain of functions in NEC9 cause Nevus comedonicus. Mutant NEC9 is leading to a fate switch within the follicular epithelium after specification. And what we're really studying now is how NEC9 contributes to cilia dysfunction and plays a role in the pathogenesis of the disease. And Katie Ellis, an MD PhD student in the lab, is really doing beautiful work in a mouse model for this. So thinking about pathogenesis, we were able to develop a pathogenesis-based therapy for porokeratosis. This work was done by an exceptionally talented postdoc in the lab, Lihi Atzmoni, who was visiting us from Israel, along with medical student Nelson Ugwu, MD PhD student Young Lim, and one of our clinical collaborators, Jonathan Leventhal. And there were certainly many others who contributed to the story as well. And so Lihi set out to understand linear porokeratosis, and we recognize that linear porokeratosis can have multiple different clinical manifestations. The first being this sort of verrucous hyperkeratotic manifestation. The second being an inflammatory manifestation. In fact, this patient was initially sent into us as an ILVEN, and you can see why when you look at this. It's clearly a linear verrucous inflammatory epidermal nevus. Then finally, we can see this atrophic manifestation as well. We know that these individuals have an increased risk of carcinoma within lesions, and ultimately we used paired whole exome sequencing to find that all of our patients had both a germline mutation, and then a second hit somatic mutation within affected tissue. And so this is a two-hit mechanism that we're seeing in linear porokeratosis. And so shown here are the results that we found from exome sequencing. All of our patients had germline mutations in the mevalonate kinase pathway, either in PMVK or MVD. And all of these mutations were predicted to be damaging and to abrogate function of one allele of this gene. But when we looked at tissue itself, we found secondary somatic mutations. And all of these were also inactivating mutations. And these included point mutations, indels, and copy neutral loss of heterozygotic. So essentially the second hit, which completely eliminates function of the gene. So I was immediately interested when we saw this falling within the mevalonate kinase pathway, because we recognize that mevalonate synthesis leads to products that include cholesterol and farnesyl pyrophosphate. Now, Amy Powler and Peter Elias had long ago shown that treatment with topical cholesterol lovastatin in child syndrome could ameliorate the disease. And finding that our mutations fell downstream of HMG-CoA reductase, we realized that if we were able to block HMG-CoA reductase with something like topical lovastatin and ultimately supply the end product cholesterol, we might not only block the toxic metabolites that come from having these mutations, but also be able to supply the necessary end product. And so we sought to treat patients who had linear porokeratosis with topical 2% lovastatin, 2% cholesterol. And the results were really dramatic. So our colleague Amy Powler treated her ILVEN patient with cholesterol lovastatin. After 5 weeks, you can see a dramatic reduction in the thickening of this lesion, dramatic improvement in the redness of this lesion. We saw continuous improvement over time. Even the hyperkeratotic variant with occlusion showed response. The response lagged, but we saw significantly better improvement over time, and the patient chose to continue therapy. Now, we also know that porokeratosis has different manifestations, not just linear, but also disseminated superficial actinic porokeratosis, which others had shown was caused by germline mutations in exactly the same pathway. And so we set out to treat some of our patients who had DSAP with precisely the same therapy, and they had a dramatic response. So at baseline, you can see this patient has widespread lesions in sun-exposed areas. He was so excited about the response, he shaved the hair off of his arms. So you could see that at 4 weeks, he had probably a 75% improvement in lesions, 12 weeks continuous improvement. And so in this case, the germline mutation is present and UV signature mutations are the source of the second hit. And so again, a really profound response that we're seeing in DSAP. And so we now know that second hit mevalonate kinase pathway mutations downstream of HMG-CoA reductase cause both linear and disseminated superficial actinic porokeratosis. Cholesterol lovastatin ointment serves as a pathogenesis-based therapy, blocking production of toxic metabolites and supplying a critical end product. We've now found that the cholesterol component of this is actually dispensable, and just treatment with an HMG-CoA reductase topically is effective. You might ask the question, why is it that patients on statins don't get better? It turns out that statins are rapidly cleared by first-pass metabolism by the liver, never sees the skin, so you must do topical application to actually ameliorate disease. I'll tell you one more mosaic story done by Nelson Ugwu with an incredible collaborative scientific and clinical team. So Nelson was very interested in understanding venous malformations. And so we had done work previously in non-involuting hemangiomas, identifying mutations in RAS, GNA11, and GNA14. Many others have been studying involuting infantile hemangiomas, which are, of course, the most common childhood vascular malformation, typically GLUT1 positive, yet seeking a clear genetic cause of those. But venous malformations were an interesting group because we knew that while there were many different potential genetic causes of venous malformations, they were not yet solved. And so venous malformation candidate genes include TEC and TIE2, PIK3CA, KRAS, BRAF, among many others. And so our collaborators approached us initially with patients who had hepatic hemangiomas But we were also interested in cutaneous venous malformations. And so hepatic hemangiomas have an incidence between 1 and 7%. They're incidentally found during imaging with a 5 to 1 female to male ratio. Lesions that are greater than 10 centimeters are often symptomatic. Rarely they can undergo lethal hemorrhage, typically in the setting of some sort of a traumatic injury. The treatment for both cutaneous and hepatic lesions includes beta blockers, sirolimus, sclerotherapy, embolization, and in rare cases, surgical intervention. So what was interesting is ultimately we found that there were incredible similarities between hepatic hemangiomas and cutaneous venous malformations, which were both previously termed cavernous hemangiomas, respectively of the liver and of the skin. And so when we look at liver and skin lesions, we see that the shared histology features these dilated sinusoidal vascular spaces that are lined by a flattened layer of endothelial cells, in this case marked by CD31 in the liver. And then we also see irregular interrupted smooth muscle cells. And so we had histologic convergence of these lesions. We wondered if there might be genetic convergence as well. And so when we performed whole exome sequencing initially in hepatic hemangiomas, we actually found that 4 out of our 5 cases had a recurrent GJA4 mutation that led to a PG41C mutation. So really fascinating to find a single recurrent mutation in multiple unrelated cases, suggesting that very restricted mutations will ultimately give rise to the lesions that we see. We did subsequent evaluation of more hepatic hemangiomas and ultimately found that 8 out of 9 hepatic hemangiomas had a GJA4, G41C mutation, and 3 out of 5 cutaneous venous malformations also had precisely the same mutation. And so GJA4 is an unlikely candidate. It encodes a connexin 37, which is a gap junction protein highly expressed in the lung, vasculature, and the ovary. And so the challenge that we faced is to understand how venous malformations, which are typically caused by these sort of canonical activating mutations, were ultimately contributing to the pathophysiology of the disease. And so we set out to express, again, wild type and mutant connexin 37 in endothelial cells to examine pathobiology. And so whereas in non-involuting congenital hemangiomas, we saw activation of AKT and mTOR, in this case, we actually didn't see that. So we saw no activation of phospho-AKT. So shown here is empty vector, here's connexin 37 wild type, here's connexin 37 mutant. So we don't see activation of phospho-AKT, we don't see activation of phospho-ERK. When we looked at other potential activators of AKT-like pathways, we looked at SGK1. And what we found is that when we expressed our mutant, we saw a shift of SGK1 expression. We didn't see canonical activation of the T256 residue, but instead we saw non-canonical activation at the S78 position. So why is this relevant? So we know that SGK1 is upregulated in hepatocellular carcinoma, in glioblastoma, and lung, breast, and other types of cancer, has a pro-survival role in endothelial and vascular smooth muscle cells. And interestingly, SGK1 expression is also upregulated by aldosterone, which is going to give us another opportunity to think about how we might be able to engage in pathogenesis-based therapy. So what we can do is we can think about what's an antagonist of aldosterone. Spironolactone is an antagonist of aldosterone, and I'm simplifying the biology that we did here. But essentially, what we found is that when we overexpressed mutant connexin 37, we saw these large vacuoles that appeared within cells. We ultimately determined that, in fact, mutant connexin 37 was blocking autophagy, and cells were accumulating autophagosomes. And so we said, well, what would happen if we treated cells that were expressing wild type and mutant connexin 37 at different time points, either at the time of induction of expression using a tetracycline-related vector, or 10 hours after induction of expression after these autophagocytic vacuoles have accumulated. And what we found is when we looked at 18 hours, that is either 18 or 8 hours after induction of the mutant protein, or I'm sorry, addition of spironolactone, we actually found that spironolactone could completely reverse autophagosomes, We also said that the same was true of SGK S78 phosphorylation. It's reversed whether we add spironolactone at 0 hours or 10 hours and assay at 18 hours. And so spironolactone is specifically abrogating SGK1 phosphorylation and normalizing cellular phenotype. And so this gives us the sense that, in fact, spironolactone might be pathogenesis-based therapy for these GJA4 mutant, both cutaneous and hepatic hemangiomas. And so this led us to understand a completely interesting and novel pathway for cutaneous and hepatic venous malformations. We recognize that mutant connexin 37 drives this non-canonical activation of SGK1. Spironolactone specifically blocks SGK1 activation and reverses it, and provides a potential pathogenesis-based therapy, which really belabors further investigation. So I'll turn now to our other great love in the laboratory, and that is disorders of keratinization or cornification, also known as the ichthyoses. And this work has been primarily done in collaboration with a research scientist in genetics, Lynn Boyden, but a whole host of collaborators, fellows, and investigators has been involved in some of the studies that I'll be telling you about today. So Bill told you the story of ichthyosis with confetti, which is something we continue to study, but which I won't talk about today. But what I'll say is ichthyosis with confetti really gave me the insight that there was a lot of room for discovery that remained in ichthyosis. And so I set out to create a registry, and our registry was incredibly low budget when we began. I brought a friend who was a nurse to a family conference of the Foundation for Ichthyosis and Related Skin Types and let us have a coat closet to see patients. And we took terrible photographs and we drew blood as best we could, but we became a lot better at it over time. And so we now have a very formalized registry that has over 1,600 kindreds that are contained within it, all recruited as trios. We've been able to provide genetic diagnosis to 1,325 of these families, which has been one of the true joys that we've had, to be able to give people an understanding of the mechanism of their disease. But we now do much more comprehensive phenotyping with history and photography. We set up pop-up clinics. This is a wonderful Yale team of medical students and graduate students who came with me to a meeting in Rhode Island where we were able to enroll 80 families in the registry. We use blood or saliva for DNA, and we do pre-screening for mutations in 51 genes that are both commonly and rarely causative of ichthyosis. And we continue to expand this panel. Those subjects who don't have mutations in known genes undergo exome, genome, and other types of sequencing. But what's really been a wonderful offshoot of this is we've created a resource of genotyped phenotyped patients, which have allowed us to really move into the clinical translational space in studying disorders of keratinization. So what happens when we look at rare and syndromic disorders? Well, our registry is enriched for patients who are mutation negative in typical screening, but we still see that common players are common. So we see a lot of mutations in transglutaminase 1, ABCA12, and other commonly causative genes. We find that mutations in 36 rarer causes of ichthyosis account for about 13% of cases, but there's still 15% of patients that remain in the discovery cohort. And so disbelievers will say, well, your technology just can't find these mutations. They're going to be non-coding mutations. And that's simply not the case. If you look at the photographs of the patients that fall in this 15%, they have disorders that don't read the textbooks. And in fact, they also have mutations in a whole host of candidate genes. And I can tell you today, we have probably an additional 9 novel genetic causes of disorders of keratinization that are simply waiting another case that we can use to prove genetic pathogenesis. And so we're very excited about the potential for discovery in these disorders. And so I'll tell you about a couple of the recent discoveries. So we were recently able to prove that dominant lamellar ichthyosis exists and that, in fact, it's caused by dominant mutations in ASPRV1. And so we ultimately had 5 unrelated kindreds that were referred to us from across the country and around the world, including Amy Paller, Heiko Traub, Jared Scott, and others. And some of these kindreds showed your classical autosomal dominant segregation with transmission throughout multiple generations. But we also identified de novo mutations in 2 kindreds, in this case, one that was transmitted, and one in which we couldn't prove that it was de novo, but we didn't have access to parental samples. And so ultimately, all of these patients had mutations in ASPRV1 detected by exome sequencing. If we look at the phenotype of these patients, and this is the beauty, you take all these patients, you sequence them first, and then you go back and you look to see if they share a common phenotype. We find that all of the patients have large plate-like scale with varying degrees of palmoplantar hyperkeratosis, with the distribution of phenotypes ranging from more mild to more severe. When we look at the histology, we see classical acanthosis, we see a compact orthohyperkeratosis, but we also see some abnormalities of the granular layer here. So we see a slight expansion and we see some larger granules that are present. And so we wondered if this might ultimately be relevant to the pathophysiology of the disease. And so what did we know about ASPRV1? Well, it turns out not a lot. We knew that it was an aspartic peptidase, retroviral-like 1, also known as SASPase, single exon gene exclusive to mammals. It has a 343 amino acid protein, 37 kilodaltons. There's a 28 kilodalton proform, which is cleaved to a 14 kilodalton active enzyme. And it's actually auto-cleaved. The active site is an aspartic acid residue at ASP212, and it ultimately homodimerizes to undergo this autocleavage event. So we ultimately were able to determine that ASPRV1 actually cleaves filaggrin, and I'll show you the data for that shortly, but it's worth reviewing filaggrin itself. So we know that filaggrin has a proform with N and C terminal domains that flag 10 to 12 tandem repeats that's processed stepwise to form monomers. These monomers are essential for keratin intermediate filament aggregation, packing into parallel arrays, and then those are cross-linked by transglutaminases to create the insoluble keratin matrix. This forms a scaffold for cornified envelope proteins and lipids, which are essential to the stratum corneum. And this provides that link back to other phenotypic manifestations of lamellar ichthyosis, which we know fall in the cross-linking phase of this process. And so we first wanted to look at the autocatalytic activity of ASPRV1 wild type in each of our mutants. And so we simply overexpressed in keratinocytes transduced to express HA-tagged forms of ASPRV1, immunoblotted with HA and anti-ASPRV antibodies. What we found is that while the wild type had the expected cleavage products, all of our mutants had an unexpected cleavage product, the unique 20 kilodalton form, which suggested that there is a derangement of autocatalytic specificity. We then wanted to study the function in filaggrin processing. And so when we had untransduced keratinocytes that were differentiated or cells transduced with wild type and each of our mutants, what we expect is that high molecular weight filaggrin is going to be rapidly processed down to small monomers that you can't see in the gel. This is true for our untransduced and for our wild type transduced. But when we look at each of the mutants, we have this massive accumulation of high molecular weight filaggrin, suggesting that there's an impairment of the processing of filaggrin, which is contributing to the disease phenotype that we're seeing here. So, this overall suggests that we're having loss of function mutations. We know that haploinsufficiency isn't the cause because ASPRV1 heterozygous null mice are normal. Human heterozygous null mutations are present in expected frequency within the population. We have these clustered missense mutations ultimately suggest a dominant negative mechanism, really enabled by the homodimerization that we see. And of course, neomorphic effects are always possible with such mutations. So overall, I think that this showed us a novel genetic cause of dominant lamellar ichthyosis. I'll tell you two other brief stories. So the next is about a progressive symmetric Erythrokeratoderma that we studied. And again, we sequenced first, found that mutations had mutations in a common gene. In this case, the gene is KDSR. But when we looked at the common features, they all had thick facial plaques. They had thickened palms and soles. They also had perigenital involvement as well. Histology was relatively nonspecific with thickening of the epidermis, loss of the granular layer, and parakeratosis. When we performed sequencing, we found that all of our patients had recessive mutations in 5 kindreds in KDSR, which encodes 3-keto-dihydrosphingosine reductase, which is required for the de novo pathway for ceramide biosynthesis. Now, we know that ceramides are secreted by keratinocytes with cholesterol and free fatty acids to form the cutaneous lipid barrier. We also know that ceramides are important for cutaneous proliferation and differentiation. Skipping through a lot of the biology that we've done, but I'm showing you the pathway for a reason, because there are three ways to make ceramides. One is de novo synthesis, where KDSR is front and center. We also know that we have a salvage pathway from complex sphingolipids. We also have a sphingomyelinase pathway that can take us from sphingomyelin back to ceramides. And this became relevant to us because one of our clinical collaborators said to us, I had a patient who had this classic manifestation, but I put her on isotretinoin. Her disease completely went away. And I said, that's amazing. And she said, you know what? She developed DISH, diffuse interstitial skeletal hyperostoses. When she was in her 30s, I had to take her off of isotretinoin, and her disease came roaring back again. Now, that patient wouldn't let us show her photographs, but another patient who had photographs over time would. So this patient, shown at 6 years of age, has this classic periorificial disease, which actually worsened over time to the time that she was 12. But here she is about 10 days after starting isotretinoin. We're seeing an effect that's far in excess of the descaling phenotype that we'd expect to see in a classical patient with ichthyosis. And we thought about what the reason for this might be. And when we went back to the literature, we actually discovered that retinoids specifically upregulate the salvage pathway of ceramide biosynthesis, giving us a perfect pathogenesis-based therapy for this disease, which is commensurate with the experience of one of our collaborators. And so, this taught us something really important about retinoids. So our retinoids are not only leading to desquamation, but we're also probably having a role in barrier composition as well. So we might be, from time to time, fixing a pathogenesis-linked disorder. And I'll finish with one last fast story. And this is about a novel Erythrokeratoderma phenotype that we were studying. Again, we used a genetics approach. We identified these two patients that had mutations in the same gene. The first referred by Angela Hernandez Martin from Spain, the second Rob Sidbury from Washington State. And these patients had distinct but linked phenotypes. They both had a congenital erythrokeratoderma. They had distinct findings with respect to hair, however. This patient had sparse or absent hair. This patient had coarse, wiry hair. Both have absence of eyebrows and eyelashes. This patient also has developmental delay and a more significant hyperkeratosis. This patient has more of what was considered to be a CIE-like phenotype. We found that both patients had abnormal nails, and also had progressive dental enamel decay. So they had rapid onset of caries, suggesting a defect in dental enamel. The histology of the disorder was relatively nonspecific, but we saw acanthyosis, papillomatosis, and parakeratosis. Now, as we were studying these two patients, I logged into the Teleichthyosis website of the Foundation for Ichthyosis-Related Skin Types. And Teleichthyosis is essentially a platform that allows people from around the world to bring their complex cases for suggestions about diagnosis, management, and therapeutics. And so every time I'd log into the Teleichthyosis website, I'd see a picture of this little boy. And it says on the website that they're grateful to the Lennox Foundation for funding this project in memory of Dane Christian Phelps. And, I had met his parents at one of the meetings of the first foundation, but I never actually knew his story. And when I looked at the website this day, I realized that he had the same exact disorder that we were studying. He had absence of eyebrows and eyelashes, had a congenital erythrokeratoderma, he had abnormal nails. And so I called his family. I said, can you tell me the story of Dane? And I said, he was a red little boy. He was a small little boy. He was a happy, healthy little boy. And all of a sudden, he couldn't breathe. And so we brought him to the Stanford emergency room, and he was found to be in rapid onset congestive heart failure. This was not something we had ever known about. He never had a murmur. He never had cardiac disease. They did everything that they could to intervene for him, but he succumbed to his CHF. And obviously this is a sad story, but I said to them, did he ever have a skin biopsy? It turns out that one of the features of this disorder are recurrent pustular flares, inflammatory flares. And a week before his death, he had gone to see my colleague, Mary Williams, and he had in fact had a skin biopsy. And so I said to the family, have you ever wondered, what caused this? And they said, of course, we've always wanted to know. And I said, do you give us consent to obtain the skin biopsy from your son? And they said, yes. We ultimately identified that he had a mutation in precisely the same gene as our two other patients. But more importantly, his discovery and his history led us to go back and look at the two other cases. We ultimately detected an undetected dilated cardiomyopathy in both of these index cases, likely at that point not progressive. So this defined for us a new syndrome, which we would call the Erythrokeratoderma cardiomyopathy syndrome, which features congenital erythroderma, defective dental enamel, abnormal nails, and progressive, in some cases, lethal cardiomyopathy. And our exome sequencing results showed that all three of our subjects had clustered de novo mutations in desmoplakin. Now, desmoplakin wasn't the first gene that we expected, because we already knew that desmoplakin caused a whole host of other disorders, primarily featuring palmoplantar keratoderma or skin fragility, but not a congenital erythrokeratoderma like what we were seeing here. So we wanted to know what was different about this desmoplakin-related disorder and the host of other mutations shown here across all the different regions of the gene. And in fact, all the mutations that we found fell within a very specific repeat of desmoplakin, spectrum repeat 6. There were also all proline substitutions. Prolines are canonical, destructive, helix-breaking mutations. And so there's something special about these de novo mutations in desmoplakin that were causing this disease. And so this was fascinating to us. And so we went and tried to understand the pathophysiology of the disease, again, using some of our common tools. EM is one of the first things that we could use. When we did electron microscopy, we wanted to look at desmosomes. We were looking for them in intercellular spaces. We couldn't find them. So we looked inside the cells, and we found that what were otherwise normal appearing desmosomes were appearing in these intracellular accumulations. Other adhesive junctions like cornea desmosomes were completely normal and normally distributed. So what's the consequence of losing intercellular desmosomes? We have opening of intercellular spaces. And this essentially creates a wide open superhighway for sensitization with aeroallergens. Also had consequences with respect to elaboration of lipids, which I won't belabor here. So this was interesting to us, and we thought might help to explain the pathophysiology of the disease. But one of the things that happens when you run a registry is you get a lot of calls. And so in February of 2019, I was contacted about a patient who had a congenital erythroderma who was admitted with failure to thrive. And when she was there, she developed rapid onset pulmonary edema. She was intubated. Her echo showed a dilated cardiomyopathy with an EF of 20%. She was listed for transplant, but they called me and they said, "We're calling you because a week ago, this patient sent their sample in. Do you know what the genetic disorder is?" I said, "Well, I have a pretty good idea what the genetic disorder is based on your description, but send me a picture." This is the photo that they sent me. And this was a baby who was clearly in significant distress, had a congenital erythrokeratoderma, but more importantly, an absence of hair, eyebrows, and eyelashes. And so I said, this is a patient who has EKC syndrome. We did rapid exome sequencing. 3 days later, we had identified a canonical EKC mutation. And my colleague, Amy Paller, and others had done really beautiful work showing that on a hunch, treating patients who had EKC syndrome with ustekinumab, which blocks IL-12/23, could actually ameliorate the skin disease. And so I immediately told the ICU team that they should initiate ustekinumab. And they pushed back with a vengeance and said, "Are you out of your mind? You want to take a critically ill child and put them on an immunosuppressive?" I said, "You talk to pharmacy." And so I engaged in an interesting conversation with their pharmacy and finally convinced them to start therapy. And what's remarkable is 8 days later, the patient was extubated and she wasn't red. And about a month later, she was off the transplant list. And so this taught us something really important. So the cutaneous findings resolved, but also the cardiac function normalized. And we want to know why this is. Well, it turns out IL-17, which is downstream of 12/23 signaling, is necessary for internalization of desmosomes. So if we inhibit 12/23, we reduce the pool of IL-17, we might actually be able to redistribute those desmosomes from those intracellular communications, collections, and then put them back out to where they belong. And so this provided the first evidence that we might be able to reverse the cardiomyopathy as well, which really drives us to think about testing all of our patients who have erythrokeratoderma early on, and thinking about initiating therapy as early as possible. So clustered mutations cause EKC syndrome. Mutations lead to abnormal desmosome processing. Importantly, this is how I get every patient who has ARCI tested. I say, "How do you know it's not going to be a lethal cardiomyopathy?" Insurers tend to agree now. We've done a lot of clinical work in this disorder. I won't go through all the details, but we have been able to define the genomic and phenotypic landscape of ichthyosis. We've been able to study mental health and the experience of patients with disease. This has been driven by wonderful clinical fellows. We've also been able to develop validated tools to assess the severity of ichthyosis. Acknowledgements need to go out to literally dozens, if not hundreds of people that have contributed to this work. And of course, I really need to thank our patients who really, contribute selflessly to everything that we do. And we're lucky to have had funding from a variety of different agencies. And so I'll stop there and open to questions.
Dr. Choate, thank you so much. And if anything, illustrates the importance of your work, it's really that last EKC case. It's really just truly phenomenal. And so thank you for such a great talk. I have a question about porokeratosis. And this is, I guess, more of a theoretical question. And I think it's a simple one. What is a porokeratosis? Is it an epidermal unit of a mutant clone running into adjacent normal clones? I know there's very specific histologic features. It's just like a corner of the mallet, just a very curious lesion. I'm curious your thoughts.
So I always know who the pathologist is in the room, but when you think about pathology, it gives you the opportunity to think fundamentally about disease, because these are what should be very small initial clones, single cell clones. And here they have a competitive advantage that allows them to expand. So the question is, why are there winners and losers within the skin? In the case of confetti, we have clear winners with white spots that expand over time. And so there's something that's happening at that interface. And the cornoid lamella is probably marking for us a bit of what that is. And so we're very interested in understanding what are the signals that give rise to expansion or regression, because certainly we know that there are some cellular proliferations, like many epidermal nevi, that grow with patients over time, never really significantly expand or contract. And yet with very specific mutations giving rise to certain types of nevoid proliferations, we do see expansion or regression. This happens in IP, it happens in certain variants of acantholytic kid syndrome. And so, my suspicion is that ultimately the derangement of the pathway allows our mutant cells to essentially provide a lethal cargo to adjacent wild-type clones. But this is an area that I think really needs a good bit more investigation, because until we can fully understand what it is that drives clonal expansion within the skin, we're going to have a hard time treating all of these clonal disorders that range from things like basal cell carcinoma to DSAP and everything else.
Great, thank you so much. I'll switch gears to a audience question. We said really phenomenal talk, and the question is how about spironolactone in cavernous hemangioma and hepatic hemangiomas clinically? Thank you.
Absolutely, I want everyone to do it, and the question, this is a simple drug that we're using for hair loss now. I think we should be using it systemically. I think we should be using it topically. I think that we need to be employing it broadly. Obviously hepatic hemangiomas are one of the great spots to use it, because they can be quite large and we can use imaging to look at them. But cutaneous lesions are really where the biology's at. So it'll be interesting to see what we can achieve ultimately, but I don't think that we're going to need super physiologic levels of spironolactone ultimately to achieve benefit. What we really need to do is we need to be able to get genetic diagnosis of these lesions to be able to figure it out. And so, we are now looking at how we can do tissue-free approaches to this. So when sclerotherapy is being done for venous malformations, withdrawal of fluid so that we can collect some of the mutant cells, we've been able to show that we can use this to do analysis, because obviously punching through one of these malformations can be a quite bloody process. So need to get genotypes, need to be able to then be able to identify the relevant cohort. But yes, something that's very interesting.
That's great, thanks. I have a question about Nevus comedonicus, and really just fascinating findings. I'm curious if you guys have looked at K10 expression or other keratins and sort of sporadic acne? Is there, or have other people, and kind of your thought on the link there?
So yes, so we and others have shown that EICs have ectopic expression of keratin 10, and so some of the least exciting banal lesions may ultimately be telling us something about genetics, and that's really been the paradigm that we've employed. So we go from the most significant lesions like the non-involuting, disfiguring infantile hemangiomas, and go back to acquired pyogenic granulomas, right? Both of them show us the genetics, just with, wholly different phenotypes. And so we have been investigating epidermal inclusion cysts and variants of acne to ultimately see how this pathway is relevant.
Great, thank you. We have another question coming in from the audience. Angiokeratomas are lesions we see in very heterogeneous contexts as part of complex vascular malformations, considered mosaic disorders like Kipple-Trinani, as part of genetic disorders like metabolic diseases, and as part of aging. I wonder if there's any similarity to what you found in porokeratosis. Have you studied their pathologies?
So yes, we are seeking to understand angiokeratomas, and there are some really interesting things that fall within angiokeratomas. And again, it's the rare and common. We're interested in both sides of it. I don't know that, well, I can't say yet. We're not deep enough into it to know that we're going to see a lot of second hit mosaicism, but I think that your inclination is probably right. The fact that we see these in people who are aging over time could suggest that there are opportunities for second hit loss of viscosity and other mechanisms.
All right, great. And just one last question. So, it's generally sort of for the audience. If providers have patients they suspect may have a disorder of keratinization, maybe they're unsure of the diagnosis, they may not have genetics available to them, maybe they're a little overwhelmed. You mentioned the Ichthyosis registry, you mentioned the Ichthyosis. Is there just general advice for how to approach those patients?
So for clinical management, Ichthyosis is wonderful. It's a free, accessible resource globally, and we'd love to see it utilized more from the foundation. With respect to genetic diagnosis, I have international partners all over the world who collect and bank samples, and quarterly send me a pack of samples and a pack of phenotypes. And we are very excited to collaborate with people nationally and internationally to advance our understanding of these disorders. And so this is one of the reasons I was so excited to give this particular talk, is the opportunity to meet people who have a common interest in improving the experience of patients with genetic disease.
Great, thank you so much. Well, we really appreciate the talk, Dr. Choate. Really, truly amazing, and thanks for spending the time with us.
Thank you very much.
Have a good day, everyone.
Bye-bye.